all. This is Dr. Mubin Sayed from drbean.com. Welcome to one more show. So, Paul, once again, thank you very much for the last talk. Here is the new talk. This actually triggered me from an article that I read where a couple of healthcare leadership or leaders or big wigs of healthcare, they were providing some messaging to us for how to handle BA.5 or how to protect ourselves. And all good, they were trying to help. The problem is, what I see is a similar, less informed messaging as was in the beginning of pandemic. At one point, I believe there are many video clips where people have put together uh, messaging where various leadership positioned folks are saying, if you take a vaccine, you would never become infected again. Or if you take a vaccine, the virus would stop at you and will not go to the next person. You will not transmit it. You will not spread it. You will not become infected with it, and so on. You have seen them. I had maintained all along that this is a respiratory virus. You cannot, I remember I used to say that there is no stop sign that would be put in front of our mouth and nose to say, now this person is vaccinated and or infected and recovered, so new virus is not allowed to enter their body. I'm seeing a similar messaging structure, but not in these words once again. That structure is BA.5 is really bad. It has escaped neutralizing antibodies. Because of that, it is important for us to get vaccinated. And regardless of that message, the problem is that in the same paragraphs of our discussions, the message also contains that this is a virus, it is more transmissible because it has escaped. So if it has escaped, then the concept of vaccine or previous infection doesn't make sense. However, the next message usually is, and I'll show you the structure, and you would see the structure repeating everywhere, is that it is still protective against severe cases. So if it is still protective against severe cases, it being immunity from vaccine or previous infection, our healthcare authorities only consider vaccine, not the previous infection. So if it is still protective, then it really has not escaped. Because if the messaging is that you take a vaccine or your previous infection are useful for not becoming infected, then that is the same message that was given earlier on, that the vaccine will not cause infection. Then the message was amended to say, no, when you're vaccinated, you may become infected, but you will not become severe. Now the message is that it has escaped, but you are still protected from severity. Do you see the conflict that is occurring in one statement? So I wanted to go over this kind of messaging and also look at data together, because whenever we Mubinize the such messages, we look at the data to see what is the reality. So one part of that was the discussion with Paul Bork. Here is the next part. So we'll start from here. And full disclosure, I am pro-vaccine. I'm not anti-vaccine. And I am vaccinated, 2 doses. I didn't have a booster because I got my infection. I think now I'm reinfected as well. So I didn't have the booster, but I was vaccinated. Okay, back here. Look at this study. We're going to go from fact to fact. Here is a study that this is June 13, New England Journal of Medicine. Updated US infection and vaccine-induced SARS-CoV-2 seroprevalence estimates based on blood donations. So what will this tell us? This would tell us how many people have the protection from severe cases, either because of a vaccine or because of a previous infection. And I should say and or, because there may be combined protection as well. For example, I'm vaccinated plus infected and then infected. So let's look at this data. So they say here that we had been, this researchers group, they're saying that we had been looking at seroprevalence, US seroprevalence from July 2020 to May 2021, based on blood donations, was reported earlier. This report includes monthly estimates through the conclusion of the study in December 2021. So it is really 6, 7 months old. So 6, 7 months ago, the seroprevalence was the combined seroprevalence, that is vaccine plus infection, rose from 83.3% to 94.7%. This is there from May through December 2021. In this time frame, prevalence went up from 83.3% in the society to 94.7%. 94.7% prevalence based on, this is a projection. So you could say, well, this is not entirely accurate because this is a projection, but still it is a very good estimate. It is based on the blood donations. So keep this in mind, that we have 94.7% of the population that has some form of immunity. Now, there is a caveat in there. The caveat is that vaccine-generated immunity wanes. And so it is possible that some people had the immunity, but then it has waned, although vaccine-generated immunity against severe cases still persists for a long time. That is the same case with the infection as well. We looked at the unvaccinated but infected cohort from Qatar a few days ago, actually last Friday, and we saw that even up to 32 months, the protection continued and waned to 10% at 32nd month. And I think it was 24 months or 26 months or 22 months, somewhere like that, about 2 years, it was still at 50%. So they were using the words years for protection. So either we say this data is incorrect, this study is incorrect, or we accept that here is the prevalence. And again, if you're not vaccinated and you want to have a vaccine, please, by all means, do it. If you got infected, you would have protection as well. The data says 94.7% of the population is protected. Now, protected from what? Will this be a protection from getting infected? No, we are seeing it. If somebody still claims that a vaccine or a previous infection will prevent any new infection, then that is wrong. This is one set of data points for us. The second set, previous coronaviruses, human coronaviruses. The diseases caused by them usually are the sore throat, cough, sore throat, painful throat. Very rarely runny nose. Runny nose was actually SARS-CoV-2 template. It was not in the previous human coronaviruses. However, human coronaviruses were known to cause gastroenteritis as well. And I have done that discussion before. The reason that they can cause gastroenteritis is because they have this membrane on them, which also has spikes on them. And these spikes kind of help them evade the acids by providing a protective cover. And because of that, this virus can cause gastroenteritis, and we know this. This is human coronavirus. What was not seen was the lower respiratory tract infection. And the reason for that, it's a reminder, we have done this discussions before. The reason for that was that SARS-CoV-2 was able to replicate or increase in numbers at higher temperature. Human coronaviruses like to stay in cooler temperature, and the upper part of the respiratory tract or the throat area is relatively cool compared to the rest of the body. Now, let me so the SARS-CoV-2 was interesting that it had the capability of replicating, increasing in number at higher temperatures as well. To me, that seems quite interesting, that how come this virus was able to do that. Anyways, it was able to do that. And that is how it caused not only deeper respiratory infections, but it also caused systemic infections. It could go to other parts of the body freely and cause infections. For it to become more human coronavirus like, it will have to wrap up its business from the remaining body and come back to the throat area. Now, SARS-CoV-2 variants you saw actually started from throat and the pulmonary system, severe cases. From there, they started expanding to the other parts of the body. Then you saw that the runny nose, which was, I still remember, in the early part of the pandemic, I once did a talk and I said it is causing runny nose in some people. And a medical student wrote, I still remember that condescending tone, that do you not even know that these coronaviruses do not cause runny noses? And here we are. Runny nose is a very common thing, and it had started. Then we saw that it went up and above. Olfactory system was involved. So anosmia started occurring with some variants. Then we saw that even it started involving the ears, and tinnitus started occurring. Brain, blood-brain barrier, and headaches and neurological symptoms started occurring. Now, if you see, it is a very interesting situation. Keep an eye on the symptoms, and you would see that it is wrapping up its behavior again from those areas, coming back towards the throat and nose. Lesser people are saying anosmia nowadays. Lesser people are saying deeper respiratory infection. Now, I want to provide one more input here. The article that I would show you, that article also is using in vitro studies. One study we saw last week from Kai Soto of Japan, where this was almost fill in the blanks. They did the same, exactly similar template with the BA.1 to say it is more fusogenic, it is more pathogenic. In vitro studies showed that it was able to infect the cells faster. They did the same exact thing with the BA.5 as well, and it was the same template. It is more fusogenic, it is more pathogenic, it infects the cells faster. And then they said, based on that, the health care of the world needs to be looked at once again. They said the same with the BA.1 as well. And we still may have a BA.5 culprit that would be really bad. I do not know the future. But this was an in vitro study. That study is being used to say that SARS-CoV-2 BA.5 will cause more deeper in lower respiratory tract infections, which is once again like Delta. And it is becoming Delta again. And then based on this in vitro study, then concluding that it is becoming as severe as Delta was, because Delta was able to go deeper into the respiratory system. Even original Wuhan variant was able to, otherwise it would not have spread that way. Then they're saying that this is becoming that bad. If that is the case, and if it has escaped the immunity, we can't say this in one breath, that one, it is like Delta, and second, it has escaped immunity, because if that is the case, we have a new pandemic. But so far, you can say, hey, UK and US, it just started, BA.5. So we have no idea what it's going to do. Portugal has already seen the peak, which is gone for BA.5. South Africa has already seen the peak. May was their peak. So we can at least look at the other, we would not map them to us. I can assure you, US will have a different outcome. Every wave, US had a different outcome. Similarly, UK. So these are not generalizable messages, but at least we can look back. We don't have to wait for the future. We can look back there. Now, with all of this, what is this? Two main points. Number one, we have zero prevalence. Number two, either this virus is more dangerous or this virus is less dangerous. The studies that show it is more dangerous are in vitro. The symptom set is showing that it is concentrating towards the throat now. Severe throat pains, congestions is more common. Yes, I know that some doctors are saying, hey, lower respiratory infections are more common. I have not, when I called doctors, I didn't hear that very often. There were people who said to me that, hey, you do not even know that people have lower respiratory tract infection. I have lower respiratory tract infection. And I mean the person who sent me the message. And I agree. I'm not saying that it doesn't cause severe cases. Severe cases will involve lower respiratory tract infection. We have a percentage of severe cases and deaths. But is it like BA.1 or like Delta? That is a question. So let's look at this little. So now we know this study's link is in the description. I actually went over this study a few weeks ago. And now let's look at this interesting article. Immune evading BA.5 variant now accounts for 65% of US COVID cases. Immune evading BA.5 subvariant. If it is immune evading and if it is bad, we have a new pandemic, right? That is what it should say. And now that means that 94% of the people are not protected. Let's see how the structure is. Top US health officials warned Tuesday that a surge of COVID-19 cases driven by the highly transmissible Omicron subvariant has arrived. So good. Yes, there is a surge that has arrived. And there are more people that are becoming sick. And out of them, there is a larger number that would go to hospital and some of them would die too, compared to the US when it was here. So US's lowest ICU numbers were in April. The previous Omicron wave was in January. And look at this. This is the previous wave. This is April. And now here we are. And if you see, we just saw that with Paul as well. This is a lower number yet. Maybe it would increase. We'll see. So this first paragraph doesn't offer anything new. Yes, it is more transmissible. That is why it is dominant. We know how to manage it, though, Dr. Ashish says. He's a coordinator of the White House COVID-19 response. We can prevent serious illness, we can save lives, and we can minimize disruption caused by COVID-19. So question, how can we prevent serious illness? Of course, by two reasons. Paxlovid, I'm talking about their tools at this time. Paxlovid and vaccine. Why vaccines? Because they create immunity. Now, if they create immunity, then really immune evading is not the right answer or right term here. Because hear this out. Even previously, vaccines were not able to stop the cases, but they were able to protect from the severe cases. That is the same message for this BA.5 as well. So then what is changed? What is changed is it is a little more transmissible and it is causing reinfections. Okay, so then, according to the Center for Disease Control and Prevention, the BA.5 subvariant now accounts for 65%. So it has become dominant. Anthony Fauci said the nation's top infectious disease said substantially evades neutralizing antibodies. Okay, fine. So it substantially evades neutralizing antibodies. If that is the case, let's just take this on a face value. It evades the neutralizing antibodies. Then do you think that the previous variant vaccines would work? We're just saying that it evades it substantially. You know that where this word came from, substantially evades neutralizing antibodies, Harvard study. And that was also an in vitro study on 27 people or 27 people's blood. While all other in vivo studies have been saying that the protection continues for severity. So, this is an incorrect statement to run with because, yes, sure, it substantially evades it, so transmits more, but there should be an additional statement here. And that should be, comma, however, comma, we are fortunate that it does not cause as severe a disease as the previous Omicron, or we are fortunate that 94% of the population has seroprevalence, because of which they're not getting in the hospitals as much as with the BA.1 and 2. And that is the data here. This data. This is BA.1 and 2. This is United States, correct? So this is BA.1 and 2 related data, these peaks. And here is BA.5. But Fauci said that the current vaccines are still effective at preventing severe COVID-19 outcomes. Good. So on one end, we continue to say it is able to protect the vaccines or the previous infection. On the other end, we keep saying immune evading. We keep saying non-neutralizing, substantially escaping. The threat is to you is now, he said. If you're not vaccinated to the fullest, then you're putting yourself at risk. Once again, 94.7%. Either we take these things and we say, you know what, these are just incorrect studies. The combined seroprevalence from 83.3% to 94.7%. It rose from May to July, or sorry, December. Okay, then here, call it the age of reinfection. Now, check this out. BA.5 puts the nail in the coffin of the myth that the virus will evolve into a milder form and fade away. Dr. Eric Topol, founder of the Scrip Research Translational Institute, wrote, so it has become more dangerous, more transmissible, but is it really more severe? We could easily see more variants. Fine, we would see more variants every day. We are getting variants every day. So what's the big news here? Indeed, a whole new family with more extensive immune evasion and growth advantage. Sure. Where is the severity? If it continues to become more human friendly, then that is fine. But the thing is, he's saying that, well, the human friendly is not happening. But then where is the data to say that's not happening? There is no data to show that. Unless, as Paul had said, maybe the government has some data that we do not know. Just like they were holding on to the data that would get misinterpreted about vaccines efficacy, maybe they have some data that they know is there and they're sharing with each other, and we are not privy to that. And that data shows to them that we have a virus that is more transmissible and more lethal. If that is the case, then we should not say this, that the current vaccines are still effective at preventing severe COVID-19 outcomes. Because then this statement has to be balanced with this statement. And you know, these cannot be balanced. And the only third way to look at this is to go and look at the data and see, what does the data say? This is UK, I believe. This is US. So then This is the only one paragraph in this article that says, none of this will set the US back to square one. Now, believe me, in this whole article from top to bottom till here, in this whole article, there is just one paragraph that tells this little truth, and it is sandwiched once in it. None of this will set the US back to square one. Despite elevated case levels, there are now fewer US COVID patients in intensive care units than there were during previous phases of the pandemic. And the national death rate, about 300 to 400 per day, is near the all time low. Acquired immunity, now look at the reason. Acquired immunity, multiple rounds of vaccination, and improved treatment options are helping a lot. So, if acquired immunity, that is natural immunity, multiple rounds of vaccination, if they're helping, then why are we saying all of this before and after? Why are we saying BA.5 puts the nail in the coffin of the myth that the virus will evolve into a milder form? Because we just captured it here. It's not able to damage us as much. So then there is a little more messaging. And though the daily US death toll is lower than it was earlier in the pandemic, it is still too high, Jha said. We are at a stage of pandemic when most COVID-19 deaths are preventable, he said. And we have said this from the very beginning of the pandemic, that there are ways to prevent. And then for the healthcare administration, it was, hey, take a vaccine that would help prevent. First they said it will help prevent against the cases, then they figured out it's not that way. Then they said very helpful against severe cases, which I agree with. Previous infection, helpful as well. What is the big point here? Just scaring people? Because this is the point all along, that if you are, at least here in our realm, we had discussed this all along. If you're going to be vaccinated or if you have a previous infection, you will be protected at least from severity. Now we are seeing with the vaccine, even then, that protection is waning very fast. So I could not understand what this little article was doing before that green paragraph and after that green paragraph was just all. When I read it the first time, I said, oh my God, we are in trouble. Then I said, how could this say that we are in this situation without discussing the severity of it? And there was that one little paragraph stuck in there. Before and after was long. Just anyway, so that is a discussion. If it was more ranty and less useful, just tell me. It is, I'll remove it. Then the second thing, tomorrow we'll have Dr. Keith Berkowitz with us. I wanted to hear his firsthand experience with the BA.5 patients in the US. Many healthcare workers are also becoming sick. Many other are becoming sick. Throat infection, throat symptoms are intensifying. So we'll hear from him tomorrow more. Day after tomorrow, I have a very interesting guest with us. You must have seen his some of his videos. I think he is Dr. Hong's pharmacy school on YouTube, and he talks about pharmaceuticals. He had made a comment under the message I gave that Paxlovid under FDA's order has become available for pharmacists to prescribe. So he left a message that he was not very much comfortable with that idea. So I requested him to come join us. So we talked today. On Thursday, we will have him as a guest to talk about this decision and what does it mean in general. So Dr. Hong's, um, he will, I think his name is Ka Hong. So anyways, he'll be with us on Thursday. Tomorrow I'm also going to be with Dr. Paul Merrick for FLCCC talk. So we're going to talk about autophagy and how intermittent fasting and some other medicines can help with that. So this is the plan. Thank you very much for listening in. Um, please like, subscribe, and share. Like at minimum. And if you would like to support this work, there are links in the description. If you are okay with PayPal, there is a link to use PayPal to support this work. If you don't like PayPal, then there is a link for buy me a coffee, or you can become a member of YouTube channel, or you can buy drbean.com plan where there are 900 videos at a rate of $67 one-time payment. That is almost never heard of. And then there are some other links as well. So if you and please tell me, I am very much interested in these two things. Number one, if you got reinfected, how was your experience? And again, if you feel comfortable, if you don't feel like putting that out in public, don't do it. And number two, do you think that we should create an app to start tracking vaccine, long COVID, and COVID related symptoms, and then have Zoe app like stats, but also including vaccine related? So thank you very much, and I would see you tomorrow. Bye bye for now.